pulmonary circulation, we're talking about the ability of the lungs to oxygenate blood that is then going to be distributed to every tissue of the body. That's the general function of the lungs, and we'll just, as a shorthand in here, refer to that as the pulmonary circuit or the pulmonary circulation. But analogous to the function of the coronary arteries, we said that the lungs have their own dedicated blood supply called the bronchial circulation, and that bronchial circulation, or the bronchial arteries, perfuse not only the active respiring cells of the pulmonary tissue, but also some surrounding tissues as well, the part of the pericardium, part of the esophagus, and various other regions. And that circulation is provided by bronchial arteries that branch diversely from the aorta. And those bronchial arteries are actually really not a pair, because on the right side they branch all over the place. They're really complicated. But the bronchial arteries then represent this dedicated circulatory system for the lungs. Now the problem we have is that there are also bronchial veins, and bronchial veins more or less follow the anatomy of the arteries, but they only carry, maybe this is worth writing down because I'm not sure I put it in the notes, the bronchial veins only carry about 10 to 15% of the bronchial arterial blood. What I mean by that is they only carry about 10 to 15% of the amount of the blood carried by the bronchial arteries.
You mean the volume?
You see the reason for that, sort of up here. If you look at as we were talking about before, there are bronchial arteries here, there's going to be a bronchial circulation here. And as the graphic illustrates, the bronchial circulation intermingles with pulmonary circulation. So most of the blood that's supplied to the pulmonary tissue by the bronchial arteries is actually gets caught up, it gets intermingled with the pulmonary blood. So be aware of that complication, but more importantly, be aware of this distinction between pulmonary and bronchial blood. The lymphatic drainage, there's an extensive lymphatic system. We saw that, in fact, in the previous slide here. You can see some of these lymphatic structures extending all through the lungs. There is an extensive lymphatic system in the lungs. In general, the drainage is distal to peripheral. That's our usual model. Each of these clusters of nodes, there are bronchial nodes and pulmonary nodes distally. Then you have these bronchopulmonary nodes and so on. I've summarized the general sequence in this slide. The pulmonary tissue, depending upon whether we're talking about the region around the hilum or distal deeper into the parenchyma of the lungs, have a slightly different drainage path. The pulmonary tissue drains into the lymphatic, superficial lymphatic plexus, the hilar region, remember that's the root of the lung, drains into these pulmonary lymph nodes, and then they converge into the bronchopulmonary nodes, the tracheobronchial nodes, but eventually it all ends up either in the right lymphatic duct or the thoracic duct, and we'll return to an examination of the thoracic duct later, but you can see the thoracic duct is large, rather delicate, and sometimes damaged in surgical procedures. This rather large lymphatic vessel that sort of ascends to the left and then empties near the venous angle into the venous circulation. So you have a couple of illustrations here showing the aggregation and distribution of lymphatic nodes. All right, as always, these discussions of the autonomic innervations send chills down our spine whenever we need to encounter them, and it's only going to get more confusing hereafter. By the time we get to the pelvic cavity, we just throw up our hands because it's almost impossible to explain what's going on with respect to autonomic innervation. But I do want to alert you, it's very easy for me as a stealthy and devious crafter of questions to trip you up with respect to the autonomic function in the lungs. So make sure that you not only know the anatomy, we've covered the anatomy, you know about where sympathetic postganglionic neurons originate for structures above the diaphragm and below the diaphragm. We're talking about pulmonary structures here, so you should know where the sympathetic postganglionic neurons are located and how they extend. But more importantly, I want you to pay attention to the function, because the functions of the two divisions of the ANS are a little bit paradoxical, a little bit unusual with respect to their functions elsewhere in the body. So for example, let's look at the parasympathetic postganglionics, and we'll talk about the anatomy in just a moment. But notice the function. They're going to, we mentioned this earlier, they're going to constrict the bronchiolar smooth muscle. So parasympathetic induces bronchial constriction. And this is unusual. Notice this. This doesn't happen in most other regions of physiology. Parasympathetic postganglionics in the lungs actually influence blood flow. They tend to dilate pulmonary arterioles. And this is more or less consistent, although we don't normally think of glandular secretion in the lungs. We're generally talking about proximal pulmonary tissue. Parasympathetic innervation promotes secretion. You might think of that as being analogous to the function in the GI tract, for example. And then conversely, sympathetic innervation is going to dilate bronchiolar smooth muscle, constrict the pulmonary arterioles, and inhibit secretion. So pay attention to the rather odd regulation of blood vessels by the ANS in the lungs. Now we're looking, before we look at the anatomy, what do we mean by parasympathetic afferents? Anybody want to give that a stab? What are parasympathetic afferents?
Like you said, bringing information back to sensing the stretch.
Okay, good. Exactly right. I just want to make sure you understand that when we originally classified the autonomic nervous system, we did so generally in terms of the efferent peripheral nervous system. But here we have a clear example of how, in order for the autonomic nervous system to do its job, to maintain pulmonary homeostasis, there must be an exchange of information. Information is coming in, that information is used to modify the information that is going out, and so on. So you're exactly right. There are going to be afferents that branch out to the bronchial mucosa. The mucosa is sort of the region around the epithelial lining. The bronchial muscles, here we're talking about smooth muscle. And also I'll mention some reflex stretch receptors. There's something called a Herring-Breuer reflex that tends to prevent you from overinflating your lungs and underinflating your lungs, and all that's also mediated by this autonomic reflex system. All right. Now, with respect to the anatomy, all of this should look very familiar to you. And you know that parasympathetic innervation to the abdominal and thoracic cavity is largely afforded by the vagus. And so when we talk about vagal innervation, you should understand that to mean parasympathetic innervation. But notice what happens here, and each of these little illustrations is a little bit different. Each of these color codings is a little bit different. In this region here, we have what are called the plexuses. And it all jumbles together. Not only does it all jumble together anatomically, but you can see this is blue here. In this particular illustration, unfortunately, color code changes with each illustration. But in this particular illustration, the sympathetic is yellow, the vagal stimulation, parasympathetic is green. So why is this blue? Why isn't it one color or the other?
That's what you get when you mix yellow and green.
Okay. That never would have occurred to me. Thank you. That's probably right. I never would have made that. I failed my third grade mixing color thing. When you take the finger paint and put it all together, they all laughed at me. Yeah, but this is the plexus, and you're exactly right. It's virtually impossible to differentiate or to discern the sympathetic from the parasympathetic. And this, as I say, even becomes more problematic as we proceed inferiorly. Now, that's the first part that I want you to pay attention to. The other part is, and you've got multiple illustrations of this. I'm just pointing it out here. They're showing what's called the pulmonary plexus here. And you can see the pulmonary plexus, this hybrid plexus of both divisions of the ANS, extends down along the primary bronchi. What they're not showing is the same thing extending up in here, extending up to the trachea and along and overriding like a spider's web, adjacent structures. That's going to be the cardiac plexus. So the cardiac plexus is I won't say it's more extensive, but it continues north and continues laterally and anteriorly and posteriorly. But in reality, I think you see the really contiguous portions of the same confusing spider's web, which we're just going to call the cardiac and the pulmonary plexuses. You should know the definition, of course, as you probably already are learning this in your other courses, the definition of auscultation and the definition of percussion. You know that with auscultation, you can listen, for example, for the peculiar sounds of the heart, or in this case, the sounds made by your patient breathing. There's a whole jargon that you will learn, stridor, rasping, all sorts of noises that you may learn to associate with specific pathologies. And of course, depending upon where you place your stethoscope, that will give you specific insights into the specific pathology. So auscultation of the lungs is very, very important. And as we talked about before, anatomically, you want to make sure you understand the upper and the inferior limits of the lungs, at least under normal conditions, how far the pleural membranes normally would extend, and inflation and deflation of the lungs, because as you tap, and you'll learn very specific procedures to tap on the patient's the back and chest. As you tap on the thoracic wall, you will hear a very specific thud, tap. The frequency will change. Not only the pitch, but the quality of sound will change, and that will give you insights into the density of the tissue deep to your percussion. So it may be possible, for example, to detect the presence of fluid down there where there shouldn't be fluid, or you may detect fluid even in the lungs. So again, just be aware of what we mean by auscultation, listening, and percussion, thumping, and listening for the sound that is returned. I think we mentioned a few of these terms before. Just know the distinction between a pneumonectomy, lobectomy, and segmentectomy. We won't watch this entire thing. What we have here, we have a young child who has some type of pulmonary pathology requiring excision, requiring removal of a portion of the lung. I don't know if it's the entire lung. We'll see in a second time. But a portion of the, I think in fact in this case it may be the entire lung. They're going to bring it out. I just wanted to show you how this is achieved. So the surgeons are talking here. They're getting ready for the procedure. Oops.
Procedure is the operation that occurs in the major fissure. And so I try to position my instrument so I have the best advantageous approach to that.
So several small holes were made in the thoracic wall, and this is more or less an endoscopic and laparoscopic procedure, the full level laparoscopic procedure. And so you can see the little instruments that he has to work with in there. So initially all he's doing is trying to isolate the region that has to be removed, either the segment, lobe, or entire lung. And then, of course, whatever has to be removed, the remaining tissue, the tissue that remains in the thorax, you have to prevent any bleeding. You have to make sure of the innervation. You have to make sure that there's not an increased risk of pathology after the procedure. So this is what he's doing. He's just cutting in here.
But here again, you can see my left hand, my right hand.
And he does this for some time, and as he does it, he's cutting through the blood vessels, and those have to be either tied off or cauterized.
You can see there is some char buildup on the instrument, and we'll clean it soon, because that is a problem. Sometimes you have to be careful that there's not sticking. And you can see this is just sealing the tissues, but in these thinner tissues, it will actually divide it. However, when we come to the vessels, we'll actively divide them after we've sealed them.
Are you using standard 3mm instruments?
Yeah, that's a good point. So in this child, we're using 3mm instruments. These again are the click lines. These are short shafted instruments, so that they're.
So he's talking about his instrumentation, which isn't terribly important. But eventually, he zeroes in on the portion of the lung that has to be removed.
And generally, in babies, what I do is I divide it and sew it close. See, look at that node. It's just totally obstructing our view. We're going to need to get it out of the way, one way or the other. I think the only thing that's very important is the first thing, and I did this actually before we became live as I went to look and make sure that there wasn't a systemic vessel coming directly off the aorta, because that's clearly not something you want to miss. So now we're going to start our dissection on the pulmonary vein. And now what I'm doing is I'm retracting the lung superiorly and posteriorly, kind of holding it up to put the vein on a stretch. And again, if you're having trouble, you can put in another port so your assistant can help you. I'm just holding it for myself. And if you wanted to get even better exposure, you could divide the bronchus. I'm going to try to wait to do that so that we don't have the air leak till the very end.
So you can see the airways and blood
Again, I'm
vessels.
retracting the lung superiorly with my left hand. So I'm kind of putting the pulmonary vein on a stretch. It's showing me these vessels quite nicely.
And of course, we have all the usual safety measures here, including blood available in the room needed, which I don't think we've ever used, and a full open set available for
So
our
apparently these vessels are sufficiently small to
Absolutely.
be
And we
difficult to
always,
tie
for
them
these, for lobectomies and PDA ligations, I will always have blood available. I would have an opportunity, I hope.
But the other thing I wanted to show you, as you look at the procedure, I wanted to show you how he retracts the
the RB2
tissue that needs to be removed from the thorax.
also works very well.
Of course, he's cleaning up here, making sure there's no possibility
Just
of
gets in the way. I
bleeding
needed
or
to drink
air
some coffee
leakage.
this morning so my tremor would be in line with the beating.
Look at he's suturing with.
Lay it down square.
One of the questioners is asking how you check for an air leak, what pressures, how do you do it?
It's a little more difficult thoracoscopically, to be honest with you. We will pour a little saline in there and have Dr. Clark at the very end of the procedure.
Like you did with your
pull
bicycle
back
tire,
your
you
ventricle
add the fluid and you look for bubbles.
and inflate the lung. And I do that
You
when
did it
I want to visualize the upper lobe inflating to make sure I haven't compromised empyreal growth.
I still do it.
So, the only problem is it can get in the way when you're suturing. It probably will here a little bit for this position.
Did he say what the purpose of this one was?
I don't recall. All I recall, and he may have at the beginning, but all I recall is that it was either non-productive tissue that could become cancerous or there was a tumor in it, but I don't recall which.
Broadcast going, so I'll show you. This is probably the most difficult part of the operation. The other thing, especially since we saw the enlarged nose, it's hard to know if there's been any significant infection or anything else going on. You don't want to release a lot of pus into the wound. So I generally have not cut the lung off before, but what I'll do is, I'll show you. All right, so you can see the field's perfectly dry. We have a nice stump closure. We'll come back and inflate it in a minute. We're gonna
Here's what you can see the tubes.
make our incision a little bit bigger.
And now he's going to retract the tissue.
That lower rib space, you can get out even slightly larger specimens that you wouldn't want to morselize, right? Pathology.
I'm spreading in the direction of the rib space. If I thought this was a specimen where I was really worried about contamination, then I would cut a glove off a.
So what does he mean there if he's worried about contamination? If it were a tumor or some other type, let's say what we call hydatid cyst or something that if it burst or broke could leave either oncogenic cells in that tissue or some infective agent. But apparently, for whatever reason, he's not worried here. He talked about using a glove to catch the thing if he needed to. But he's not concerned about it here, so he's not worried about fragments of the tissue remaining in the thorax.
A finger off a surgeon's glove or something along that line.
But what is he pulling through there? That's either and there you
So
go.
there's our inferior pulmonary vein. There's our bronchial stump. There's our pulmonary artery. We may not get a good one. I'm very comfortable with that closure, and what we'll do is we'll put a chest tube in, and before we wake the baby up, there we go. We'll try to get a look at it. We may not be able to. All right.
So I just wanted you to see how they extracted it. I thought that was interesting. Be aware of what we mean by an embolism. There are all kinds of embolism, but in the case of a pulmonary embolism, there have been several well-known individuals who've passed from this condition in recent years. I can think of a couple of newscasters, for example. With respect to the pulmonary embolism, what are we talking about here? What do we mean by an embolus? All right, so Louise says a clot, so that's the most common type of embolus. Embolus just means something that blocks the arterial circulation. If it's pulmonary, it's going to be in the lungs. That means that portion of the lungs is not going to receive adequate blood flow. But in reality, an embolus could be any number of things. It could be an air bubble, for example, anything that blocks the flow of blood. And of course, if a significant portion of the lung is blocked from receiving adequate blood, that tissue over time will not oxygenate the blood that's passing through the body, and moreover, if the condition is sustained, that tissue in the lungs can become necrotic and no longer functional, and depending upon the extent, the field of the blockage can even be fatal. We won't worry about that. You probably weren't aware that vegetation can grow in a human lung, but we won't worry about that.
Really?
Yeah.
I had a quick question with
Sure.
respect to the bronchial circulation.
Uh-huh.
85% of that intermingles with the pulmonary. Is the implication of that that it gets reoxygenated before it gets back to the heart?
Yeah, I think so. Yeah, you're exactly right. I think though that if you're asking about the way that the bronchial blood is returned to the heart, yeah, it ends up in the pulmonary circulation, and the percentage or the proportion that is oxygenated and the proportion that is not, I really couldn't answer that. I don't think you'd find a very satisfying answer. I don't know that that's been worked out. All that is very clear is that the bronchial circulation, for the most part, ends up in the pulmonary circulation. Even though I think I have a slide later on with those bronchial veins. Their function is somewhat limited. All right, there's a brief discussion here of the mediastinum. There are only a few points that I want to stress in this regard. Make sure you understand what we mean by the mediastinum. That's that intervening region between the two pleural cavities. It contains the heart, pericardium, the roots of the great vessels, for example, superiorly up there above the base of the heart, includes the thymus, the esophagus, the trachea, all those structures that are sort of lying between really everything in the thorax except for the lungs. And as we consider resides in the mediastinum. It's a fairly flexible tissue. Remember the pericardium, which is the largest sac, pericardial sac is the largest component in this region, arguably, is adherent to the diaphragm, so it's going to be moving up and down and probably moving all the structures in the proximity. The pericardial sac is also attached to the anterior connective tissue, the manubrium, the sternopericardial ligament, so that when you're breathing and your chest is moving in and out, that's going to be causing changes in the conformation of the mediastinum. So this is a very labile tissue containing a large number of structures. I was watching somebody on a lawnmower the other day out here mowing the grass along the side of the road. He looked to be middle-aged, and he had the facial covering on, he had the ear covering on, but in that seat he was just bouncing up and down, up and down. And I'd love to see, maybe some of you have seen this, the epidemiological consequences of doing that every day, just jogging the viscera up and down, up and down. I'm inclined to think that there would be some adverse consequences over a long period of time. But nevertheless, my point here is that you do have structures in the mediastinum that are designed to accommodate almost ongoing changes in position. So be familiar with this region we're talking about here. We'll talk a little bit more about each of these components a little later. But at some point you'll need to know, for example, the orthogony of these great vessels and how they originate from the heart at the end of the heart. And to that end, you have a cadaver specimen in the large image here and sort of a key here. So you should be able to identify all of the structures, the aorta here. You can see the vena cava and the brachiocephalic veins on either side. You can see your brachiocephalic trunk of the aorta here, the carotid, subclavian. And then As you can see also, as you look at the base of the heart here, you should be able to position, for example, the aorta and know what this structure is based upon what you're looking at down here. So what I'm suggesting is just make sure that you are able to identify these structures in terms of the key here. I will not ask you on a test to tell me what structures are in the anterior, middle, or posterior mediastinum. But I do think this table might be useful. Perhaps you could have be looking at this table while you break out your essential anatomy 3D model and make sure you appreciate how it is that each of these structures are in these formal anatomical compartments. Our job here is not to become scholastic anatomists, but when we talk about anterior mediastinal structures and posterior, you should have a sufficient sense of the anatomy to be able to differentiate which structures belong in which of those regions. All right, let's talk a little bit about the pericardium. We learned when we talked about the lungs that the lungs are surrounded by a bilayer membrane we call the pleural membranes. There's a similar sort of arrangement with respect to the heart. The heart itself is encapsulated by a multi-layer or laminar structure called the pericardium or the pericardial sac. We talk about the exterior fibrous pericardium and a more interior serous pericardium. And as we pointed out earlier, as you look at the pericardial sac down here, sort of in green, it's adherent to the diaphragm, the anterior thoracic wall, and even to it's sort of bound up, as we'll see in a moment, with the great vessel superiorly. Now we're looking in the bottom image at the wall of the heart. So this would be the myocardium of the heart here. This would be the heart muscle. This would be the interior wall of the heart. That's called the endocardium. And then, still contiguous with this overall mass of heart muscle, there is this outer layer here, sometimes called the epicardium. But as occurred with the pleural membranes, how well you can see this, but this layer and this layer, this light-colored layer, they're actually part of the same membranous system. And they come together. Remember, you can see over here where the lungs, we talked about the pleural sleeve. Well, very near the roots of the great vessels, right up to here, if you pay attention to the green line and the blue line, the pericardial membranes join together superiorly as well. So in reality, the two layers of this serous membrane come together apically at the roots or at the base of the heart there. In between, so again, this is the myocardium, this is the endocardium here, and we call this the epicardium, which is a layer that's really continuous with that light-colored layer. But in between those two layers is sometimes called the pericardial space, and as with the pleural space, it's filled with a small volume of lubricating fluid that allows the two membranes to move relative to one another. And as with the pleural space, sometimes this region can become overfilled with fluid, or there can be insufficient fluid and resulting adhesion. We didn't talk about adhesions in pleural space, but that can happen here as well. Superiorly, and the anatomy of this is much more complicated than we need to get into, but superiorly, where the two components of the pericardium, the two components of the membranous pericardium come together, there's a little opening, and you can see the sort of trajectory of that opening there, and you can see the individual introducing their finger into that opening. And anatomically, clinically, that's sort of fortunate because that opening, as you can see, would allow application of structures or implements that would restrict the circulation, being bypass procedures or temporary surgical procedures or whatever. But that's called the transverse sinus. Transverse pericardial sinus. Now here we can see the two layers, a little color here, we can sort of see the blue layer and the brown layer of the pericardial sac. Exterior to that is this outer layer of the fibrous pericardium that consists of at least two different types of connective tissue. There can be adipose tissue in that exterior layer too. But it's in that little white region that you see there that the fluid would be located, the fluid of the pericardial space. And you can see the individual here putting their finger in the transverse pericardial sinus. And so that would enable, for example, clamping of the aorta or clamping of other associated structures. The pericardium is supplied by the pericardiocophrenic artery, and there's a similar arrangement of veins. The pericardiocophrenic also innervates some other structures as well. Innervation of the pericardium is achieved primarily by the phrenic nerves. The phrenic nerves are the same nerves that innervate the diaphragm, and they do so on their way down. And they seem to, there's speculation or debate about this, but they do seem to provide nociceptive information. Yeah.
Just on the note of the phrenic nerves, is there one that's more responsible than another? Because there's just, I guess, on some slides it says C4, on some it says C5.
Oh, you're asking about the origin of the cervical or brachial plexus, the origin? No, I've never seen that. Some slides you will see a difference. I think what that means is, how I've always interpreted that, is that the phrenic nerves originate diversely from several spinal nerves, and depending upon the tissue or the region that is supplied, well, they're simply pointing out that it's preponderance of those components that contribute to those ultimate nerves. But I don't know if that's accurate, if my interpretation is correct or not, but that's how I've always interpreted that.
Could be brachial or cervical plexus.
I think so, yeah. And I think that's the way I would leave it. But also keep in mind, so my point is there probably is nociceptive information being returned. I think the phrenic nerves is being a muscle nerve innervating the diaphragm, but they also seem to supply the nociceptors as well. But there's also autonomic innervation of the pericardium. So when we talk about the vagal and the sympathetic trunks, we're generally talking about structures that, especially with sympathetic, that regulate blood flow into this region. I heard them talking at one of the meetings recently, one of the faculty meetings recently, about whether you should be able, in the time you leave the program, to recognize these conditions in a radiological image. I don't think they ever came to a decision, but it does give you a good, fair warning. So at the very least in here, you should be familiar with the terms. Pericarditis just implies inflammation of the pericardium. It can be primary. The patient may have a variety of symptoms, everything from chest pain to maybe fatigue, or it can be secondary to some other condition. For example, you probably know that a lot of literature exploring the relationship between dental infections and dental problems and pericarditis. Pericardial effusion just implies that for whatever reason, the fluid in the pericardial space is increasing, and as that fluid increases, think about what the pericardial sac is doing. We've already indicated that it's attached to the diaphragm, it's attached anteriorly, it's attached to the great root. It very much restricts the ability of the heart to expand. All right, if you introduce fluid into that pericardial space, depending upon the volume of fluid in there, that's going to further restrict the ability of the cardiac tissue to expand. If the pericardial effusion actually creates an inhibitory and restrictive condition on the heart, such that the heart is no longer able to fill with blood properly, we're talking about the ventricles, then that's called a tamponade. So tamponade is a condition that generally has to be addressed either through some type of pericardiocentesis, in which the fluid is drained off, or some alternative surgical procedure. We looked at this before. I just sort of want to remind you that this little figure is useful in establishing your anatomical reference system For example, I always think in terms of the sternal angle. Sternal angle is very near T4, T5, and the sternal angle, as you'll notice, is also very close to the superior margin of the base of the heart. So that's a good way to sort of keep that straight. And then at about T8, T9, you have the inferior margin, what is sometimes called the subacute margin of the heart. I have no idea. Does anybody know why the region or the inferior margin toward the apex is called the acute margin? So we've talked about the terminology used to describe the wall of the heart. We've indicated that the thick muscular wall, especially on the left side, is the myocardium. The epicardium, remember, is a portion of the pericardial sac. It's actually just that outer layer of the heart wall, which forms a part of the pericardium. And then the endocardium is this interior wall that you see here. One of the curious things about the endocardium anatomically is that it does not appear to be perfused by the blood vessels that, by the coronary vessels, the vessels that perfuse the heart muscle. So the mystery has been, for many decades, if the coronary vessels do not supply the endocardium, how do they remain nourished? How do they remain vital? And there's a lot of debate about that. Could be from diffusion, either direction. I'm not sure that's been worked out. Let's see, anatomically, I think we've already talked about all of these structures. There's a region called the aortic vestibule that is just below the aortic valve. I think we'll have a better picture of that a little later. And we'll talk about some of these other structures, such as the trabecular cardium in more detail in just a moment, too. What was the annulus fibrosus? Right, and so we're looking here. This isn't terribly important, except what we're looking at here is the sort of, well, it's sometimes called the cardiac skeleton. It's not really a skeleton. There's not bone here. And this is more of a fibrous material, more of a collagenous material. But we're looking at the skeletal framework into which the valves are positioned. And you can see the two openings for the AV valves and the two openings posterior for the semilunar valves. So you're right. These are going to be placed or ensconced within that annulus fibrosus. Sometimes you'll see the reference to the term trigon, and that's just a portion. For example, this would be one of the trigons here, just a triangular region of the cardiac skeleton. There's the left fibrous trigon there, the right fibrous trigon, and so on. But you see the relationship between the two AV valves and the two semilunar valves. We're going to come back and talk a little bit about these coronary vessels and the veins in just a moment. But in this illustration, just big picture, make sure you can identify, if I were to show you an unlabeled image such as this, make sure you can identify, for example, the three large vessels at the top base of the heart there. Make sure you can identify the pulmonary veins. We'll talk about some of these structures here in this coronary sinus in just a moment. Notice by the way, are we looking at the heart from behind or in front? All right, so this is a posterior view. Remember, from an anterior perspective, the apex is going to be pointing down and to the left. But notice in this posterior view that you have the vena cava is fairly clear. You have the SVC and the IVC pretty much lined up there, emptying into the right atrium. Anterior view here, so again, be able to identify the sequence of the great vessels. In this image, you should know that here this region is called the interventricular septum, and by that we mean this anterior wall that you're looking at from the anterior perspective consists chiefly of right ventricle. So all of this is the right ventricle, but on the other side of that is the left ventricle, again separated by this interventricular septum. We also see in this image the atria here, and they have a couple structures called auricles. Back when I was in high school, back in the 14th century, when we talked about auricles, auricle and atria were used interchangeably. Now we have different terms, but in this illustration, which is a little bit dated, the auricle refers to a little sac-like region, at the margins of the atrial chamber. They're now called atrial appendages, but the reason that's important for you as a PA is because this sometimes blood can get sort of remain stationary. It can just as the blood is cycling through the heart, regions and portions of blood will remain in that region, get caught up in that region like eddies at the side of a river, whatever, and start to coagulate. And then if that blood is then for whatever reason propagated elsewhere, that can, when we talked about the embolus, that can be problematic. Yeah.
What function do the oracles serve?
I don't think they're. I think they're probably vestigial, and we'll come to a slide in just a moment, which we see some other vestigial structures that are left over from when the mother circulation bypassed the heart. But I've never seen any explanation regarding the function of the oracle.
Would you also say would that be an example of a brewery that we could hear?
You can certainly hear bruits, but I'm not sure that you would hear them there in the atria. Anybody know? Do you hear the? Do you have any authorities on that? I don't think there's sufficient pressure or turnover that you would hear it there. Generally, what you're hearing there are the valvular consequences of any impairment in flow. Possibly, I've never seen that, I've never heard that. Again, from the posterior view, again, we're going to talk about the coronary sulcus with these structures. We just recognize where the apex is and recognize that we're looking at the heart from the posterior perspective here. And and the other thing I wanted to mention is that you also have a posterior interventricular sulcus, such that from the posterior view, most of this is left ventricle, this is right ventricle. As we look at the section of the heart here, we've talked about most of this in the physiology, but for the anatomy, make sure you can recognize the AV valves, differentiate those from the semilunar valves, be able to recognize the coronary arteries here. You can see them cut there. Of course, be able to recognize and differentiate the atria from the ventricles, and be able to recognize the large myocardial wall on the left side versus the right side here. In this image also, we see the chordae tendineae of the AV valves. That's these little white lines that we have here. And the chordae tendineae are attached to the papillary muscle here. There's usually a papillary muscle for each of the cusps. Remember, there's 3 on one side and 2 on the other. On the left side, they're about the same size. They're not. In fact, we don't even see them in this image on the right side. They're highly variable. The little trabeculae that you see here, the little tendrils of myocardium, these are called trabeculae carni. Carni just implies flesh or muscle, and the function is debated, but it's thought to increase the efficiency of ventricular contraction. There's some other structures we'll come back to, but I think that's the bulk of what we need to know there. We've talked about the auricles and the atrium here. You can see the little auricular component there. Again, the modern term, the preferred term, is atrial appendage to describe the auricles. Are we looking at the heart from the front or the back?
Front.
Is that anterior or posterior? Okay.
Anterior lateral.
So as David was asking about the function of some of these structures, there are a number of terms on this slide that refer to vestigial structures, embryonic structures, fetal structures that were present to facilitate the exchange of blood in the fetus before the heart was functional. We don't need to worry about how all that embryological differentiation occurred. Certainly the fossa ovalis. You've got the sinus venerum up there, sinus venosus. These would all be vestigial structures. The only relevance for you, I think, is that in some cases that process of differentiation may not be complete, or it may be completed in appropriate ways, and sometimes these vestigial structures can create openings in the wall, for example, in the septa. Some cases, this is another structure right here. They can sometimes cause problems, the ligament there. But other than that, we will not be too concerned about these structures. Now, in the right atrium, you see a little ridge of a little trabeculae here. These are called right pectinate muscle. This is only present in the right atrium, not in the left. And you can see the pectinate muscle here in the wall of the right atrium. You can see the fossa ovalis here, which we indicate in some cases does not close properly, but it is that one of those vestigial structures. The slide here is pointing out the interventricular septum. Just notice that in most individuals, the inferior portion is quite massive and quite muscular, really contributing to the contraction of the left side of the heart. The superior portion of the ventricular septum is called the membranous portion. Yeah, there it is.
There it is.
And really just folds into the annulus fibrosus and becomes part of the annulus fibrosus. And then finally, before we take our break, the other thing I wanted to mention here, I think it was in one of these slides, there's going to be, you know the papillary muscles, you can sort of see them here, although this particular cadaver image is not the best of them. But in the heart, in the ventricles, there are sometimes dedicated sort of electrical anatomical passageways for those Purkinje fibers to proceed directly to the papillary muscles. And those are called, those passageways, those little conduits are called septomarginal trabeculae. So these trabeculae are distinct by the fact that they're distinguished or differentiated by the fact that they include that conductive pathway that allows the papillary muscle in most cases to be tensed or tightly or slightly contracted in it before the rest of the myocardial wall is contracted.
Dr. King, that says only the right atrium muscle.
Right.
So the left papillary muscles don't get that tense.
Are you asking, are there septomarginal trabeculae on the left side? Or?
Yes.
Yeah, I think that there are, but I'll check. I know that when you look at these, I took a histology course in graduate school, and you could definitely see enlarged Purkinje fibers going into the papillary. I assumed that this term referred to the same structure, but I'll check. All right, let's take a break.